Hello, everyone. I'm Sherry Rolfing, your host of the ACAP SDOH Health Equity Showcase. I'd like to welcome you to our session presented today by Siftwell. They will be discussing precision SDOH, tailored solutions for community health plans. But before I turn it over, I have a few housekeeping items. This session, along with all ACAP calls and webinars, will be held in accordance with the ACAP antitrust guidelines. These guidelines can be viewed on our website. We will record today's call and we'll post it and the slide deck on the SDOH Health Equity Showcase website. Always remember, if your plan is seeking services, be sure to check out our list of preferred vendors, just like Siftwell, on our website. Look to the top of our homepage, click on the preferred vendors link. You can also post a note or even an RFP on the preferred vendor connection portal. During today's session, you can ask a question at any time by clicking on the Q&A icon in your Zoom window and type it in. Now I'll pass it over to Trey to get us started.
Great. Thanks so much, Sherry. And big thank you to everybody dialing in today. Appreciate you making the time. We love for these to be conversational as much as they can be. I know this format doesn't afford us that opportunity, but as we move through this, please ask questions where you've got them, and we'll pause on those. What we wanted to do today is first start out with some introductions from the Siftwell team members that we've got, in particular, Eben and Kim. Talk a little bit about, what is Siftwell, what we do, go into a case study, and then talk a little bit about how we do the work that we do on behalf of ACAP plans. So let's get started with some introductions. Eben and Kim, will you please introduce yourselves?
Well, good afternoon. My name is Kim Webb. I am the Vice President of Health Strategy. I have been in this industry for over 20 years. I have a clinical background as a registered nurse and have been leading teams from an MCO perspective for the last 10 years. So it's a pleasure to be here with my esteemed colleagues, Eben and Trey.
Thank you, Kim. Good afternoon, and thank you very much for the time this afternoon. My name is Eben Estes, and CTO and co-founder of Siftwell. I have a data science background and specifically behavioral modeling. So previously working in big tech, essentially using machine learning techniques to predict attitudes, to change those attitudes that then ultimately change behaviors that then lead to different outcomes for these members, and applying those algorithms in a healthcare setting. So thank you very much again, and very excited to chat with you today.
Thanks, Eben. And again, my name is Trey Sutton, one of the co-founders here at Siftwell. Spent the last 25 years working mostly in the public sector around affordable housing, improving healthcare. Previous to starting Siftwell, I was the CEO of an ACAP plan. We had about 1 million lives in North Carolina. And then before that was the CFO of Medicaid in North Carolina, and really saw an opportunity to do a better job of identifying individuals and matching them with the right services and supports at the right time, at the right levels. And so that's really the genesis of Siftwell. We take managed care expertise, in particular expertise that's born out of ACAP, like MCOs, regional plans, and we combine that with technological advancements in the areas that Eben mentioned, like artificial intelligence and machine learning. We're not your average company, and this presentation may not feel like a traditional one. We're not going to just put a platform in front of you. And that's part of the reason that's true is not only do we have a platform, but we also bring the expertise. So it's really the combination of those two things. The other things that make us unique is that we're specifically built for community health plans, diverse populations, individuals that are covered by Medicaid, Medicare, and Marketplace that have unique circumstances and unique needs. We also take all the learnings that we get from one client to the next, and so that the models that we're going to walk you through today and the examples are actually is real world examples from one of our clients, and where there's opportunities to carry that forward to another client in a non-competitive geography, we always do that. The next thing is we run the analytics both plan-wide and then all the way down to the individual. That also includes geography, populations, disability categories. You'll see a full pyramid, if you will, moving from the top of your plan all the way down to the specific member and their individual needs. And then the last bit is we're like part of your team. So this isn't something that we run, throw over the wall, and hope that you're successful in running the various initiatives and campaigns. but rather we stitch in with your teams, be that in quality, population health, whatever the team is, we actually sit with you alongside, plan those initiatives, and help you run those campaigns. In terms of how we do it with our clients, it's really 4 basic steps. First, we want to understand your priorities or your objectives, the resources that you've got, the capacity, and the programs. That's a really important thing, because what we don't want to do is give you insights that you can't do anything about. So that's one of the key first steps. Next, what we do is we take your data, clean it up, stitch it together with our data sets, and we'll talk a little bit about what those are. And that serves as the basis for all the analysis that we run. Third step in it is identifying the root cause that your members or your organization is experiencing. And what flows out of that is specific recommendations for individuals or programs that you can act on. We do those 4 steps across population health, quality and care gaps, SDOH, risk adjustment, member growth and retention, as well as program evaluation. We're going to talk about SDOH obviously today. So Kim, do you want to pick it up from here?
Thanks, Trey. For our listeners and viewers, you can see me.
Hey Kim, you're coming in
Thanks.
quiet. Oh, there you go.
Thanks, Trey. For our listeners and viewers, I do exist. I am not a chat bot. Evan did not create me. I actually exist, just having some video challenges today. So, challenges associated with SDOH. You see the bullet points on this slide. And so, what I want to talk about is there's an intersectionality of institutional and structural SDOH with health equity. The intersectionality is linked to unequal, unjust, and unchecked policies, programs, power, privilege, practice, and preferences at an individual, community, and population level that have social historic context that has now manifested to this moment in healthcare, where industry, national, state, and local mandates are now being created to curate, address, and advance health equity and social and economic determinants and drivers of health. You notice that I said determinants and drivers. I think that's important because when we think about drivers, we think about health related social needs, and determinants are finite. So as you look at this slide, you'll see 4 key points that at Siftwell we have experienced with some of our clients and through our data analytics have found tend to trend across many population types as well as MCO types. Understanding individual needs, context, and root causes. There is an intersection of environment to justice and chronic health conditions, whether communities are exposed to pollution because they live near railroads, highway, industries. And you'll see that primarily in one of our case studies with our Native American indigenous communities that we're going to highlight in our case study. This tends to be a marginalized community. They are often invisible and left out of the discussion of SDOH and health equity. And so understanding the individual unique needs of this population is critical, as well as the root causes. Those root causes can be due to lack of adequate and quality infrastructures. We saw this proliferate during the COVID-19 pandemic. Then we have data. Um, we always say in this country we're data rich. There's a abundance of data, but we know that gaps exist for marginalized populations. That's because data sets don't tend to be deaggregated to see how processes and outcomes differ by demography as well as geography. Creating benchmarks to identify variants for population cohorts. We'll highlight that in our case studies so you can see how we benchmarked, identified those variants by population cohort. And then we also recognize that with our qualitative data, there's an underreporting by individuals due to the mistrust of the system. We take that into account when we're analyzing your data. This third bullet, SDOH directly impacts business and performance in multiple ways. Well, because of the systemic and structural determinants and drivers, it is a national public health crisis that impacts all of us in the United States. This disproportion and this crisis has disproportionately resulted in potentially preventable admissions, readmissions, and increased utilizations being higher in marginalized and vulnerable communities. And last but not least, because of all of these drivers and health inequities, our national, state, local, and tribal governments have now put into place requirements and expectations. The White House, the United States Department of Health and Human Services, through CMS, have released guidance to drive MCOs, industries, commerce to come together and address these social determinants of health and to ensure that health equity is at the forefront of what we do.
Yeah, and to just add to what Kim's saying, quite often we see that members that are most impacted by health-related social needs live in environments that are very challenging, but then also have this inherent distrust of healthcare services. And we do see lower levels of engagement frequently being associated with members that live in challenging environments. And the case study that we want to talk about today specifically addressed this issue, where we had a segment of their membership living in a very difficult environment and just not engaging with healthcare services that would lead to better outcomes for these members. So this particular case study, the client were very interested to try to understand the care needs of their particular membership, and specifically the psychographic profiles of these members, and trying to figure out, like, what are the reasons for them not wanting to take that first step to look after their health, to try to improve their outcomes. The data that we're using to identify these members is a combination of regional data sets. So it's pretty well known that we can look at census data and census tract data in order to look at poverty metrics or historical utilization patterns. But what we also do is we also look at food access data. So we look at very narrow definitions of zip codes, how many supermarkets are available to those members, what's the density of junk food restaurants in those areas. So food access being incorporated into the analysis. And then also very well-known issues along the lines of transportation barriers and psychographic attitudes around healthcare, vaccine benefits, and so on. So essentially aggregating all this location-based specific data to come up with a physical environment estimate of who these members are and what's driving their outcomes. But then very critically also generating predictions at the member level to try to predict what their individual situation might be. So in situations where Z codes are documented, for example, we have the ability to see who's having trouble with housing and economic circumstances, or literacy, or issues with their physical environment and psychographic situation. We also have the ability to predict certain types of care needs based on recent claims activities that we can detect for these members. So trying to combine this individual care needs prediction with a regional SDOH prediction to try to understand the root causes of why these members are not engaging with preventative services, and helping our client figure out for a particular segment of their population who's having an issue with their environment and how is that impacting their utilization of services. How can we help them? And this particular campaign that we worked with, after running the campaign with them, we managed to improve renewals for this particular member population. So again, this was with a marketplace product. So we improved engagement for this particular membership, and we also improved the retention for these members after running this campaign that very specifically focused on helping them address some of their SDOH challenges in seeking these preventative care services.
And then, Evan, we just had a question come in from Deborah. Deborah, and the question was, after the initial, or how is the initial outreach performed? Do we do that, or does the plan do that? We don't do that part, but what we do have is a network of, excuse me, of trusted partners that can run SMS campaigns, call campaigns, can scale in any which direction. Most often what we find, though, and this comes back to that first step, which is understanding how you're structured, how you're organized, and what resources you have. Do you have a call center? What does your care navigator team look like, or care coordination team look like, et cetera? So understanding that upfront will enable us to provide recommendations, campaigns, initiatives, whatever we want to call them, that actually just dovetail right into what you already have the capacity to do. And where you identify opportunities where you don't have the capacity, that's when we can bring partners to the table. So.
Absolutely. So just to kind of echo what Trey is saying, that our first focus is powering your team to do what they do best. So trying to figure out where should you focus on a particular problem, like who are the members impacted by that problem and what you can do to try to improve their outcomes. That's fundamentally how we try to work with your team. So if we go on to the next slide, the where to focus the problem is one of the key inputs into the start of the process. So as long as the data that you provide us have some kind of zip code data or address information that we can map back to a regional location, we have the ability to then identify areas of your membership that are dense with certain members that are faced with SDOH challenges. So again, this is for illustrative purposes and client data has been obfuscated. But for this particular client, we identified a cluster of members that were very much impacted by transportation barriers and housing insecurity. So this particular area, very dense with members with those characteristics, and very naturally an environment of members that we needed to focus on in order to make a difference. Now, what's critical about Siftwell is that in addition to knowing where the problem, needs to be addressed, we also do what you can call a social network model of everything happening in this area. So if you think about a social network as people being connected to other people, what we do with your data is that we build a social network model of the members in this environment and who the care providers are that they're interacting with in this environment. We also look at who are the community-based organizations in this environment that you could potentially work with to try and help these members. Who are the community-based organizations that can help them with food insecurity or social support or with their transportation barriers? So really trying to understand, like, what are the human connections in this very narrow cluster of zip codes that we can work with to try to make the outcomes for these members better is one of the key starting points for us in order to make these programs more effective for your members. So once we've figured out where these members live, we do a second step in the analysis where we then identify the clusters of your members within that region that all have the same statistical driver as the reason for them having a certain type of behavior. So what you can see here is that every single one of these plots is essentially a group of members that live in that area with the challenging SDOH situation that have very low levels of engagement with their preventative care services. So these are the groups of members that all have the same statistical drivers that make it unlikely for them to engage with preventative services. And obviously the goal of the campaign is to identify what do we need to do with each one of these groups in order to get them more engaged, in order to get them to renew their membership and seek the preventative care services that are covered for them. And then trying to help our client with that outreach to prioritize who should be matched to which particular member in order to make that outcome a reality.
I think what's really important, all that Evan said, the nudge that a facility nearby offers relevant service, we empower our partners to decide which data is relevant to move to actionable, intentional strategies and tactics. So it's taking things from a high level, we make it very granular for you, but we take it to a point where it's like, this is actionable so that it leads to outcomes that matter. And I think that's what this, as an operator, having a team, a very large team of 1,000 individuals at one time across Medicaid, Marketplace, and Medicare, that's really important. You want actionable, intentional insights so that you have outcomes that matter for the organization as well as for the individuals living in your community that you serve.
I think it's a really good point, Ken. I mean, the other thing that, and again, I didn't know some of this technology was out there until I met Evan, and that was the genesis of Siftwell. But, for me, particularly running a Medicaid plan, there just never was enough resources. And when you look at the list of things here, and you can add wellness visits, medication adherence work, behavioral health assessments, whatever it is, we can all agree everybody in your plan should have that. But what's unique and different about the technology that we've built is we're not saying everybody in your plan necessarily needs it. Everybody should get it. But how do we figure out the ones that absolutely need it? And those things should be prioritized for those individuals, at least for the care manager to take that into consideration as they're doing outreach. That's the cool part. So
absolutely. And our goal is not to have a web page you log into to look at a bunch of pretty numbers and pretty charts and slides. Our goal is very much to work with you on designing specific campaigns that have very clear KPIs with very clear next set of actions to try to help these members have different outcomes, and then working with you on a monthly cadence to track how those campaigns are evolving over time in order to see, if we're moving the needle with having these members having better outcomes. So on the topic of, what we're doing, imagine those scatter plots that we just looked at. Imagine just clicking on one of those dots. It would essentially show you a particular group of members living in that area of, health-related social needs, and then essentially giving you a lot of metadata about what a psychographic profile looked like for these members that live in that environment. What is the expected behaviors that they're likely to exhibit over the next couple of months? What is their likelihood of seeking primary care? What is their likelihood of, being adherent to their medications, and so on and so on. All this data we then provide to your teams as a benchmarking step in our analysis. The really important thing that, go ahead, Kim.
I think one important thing here, and I'm sure you're going to get to it. I took a moment because you paused there, Evan. I was like, we cannot leave this out. I want to highlight it, emphasize it, is the preferred modalities. I think this is really important because every organization across the country is trying to figure out, how do we create value? And how do we engage our members? So this preferred modalities is very important. I know we were always looking at what our members going to respond to. We still do a lot of outreaching by phone, but as you can see, it's text messaging. And oftentimes we think text messaging is for a younger demographic. But if you look at this case study, you can see that's not the case. These women are between the age of 55 and 64, and they're responding to text messaging. So I think one of our participants asked earlier about who does this outreach. These insights give you the ability to say, okay, we need a text messaging campaign. We don't have the capability to do this in-house, but we have point care solutions that we can say this organization does this very well, so that you can ensure that you are increasing your member engagement, so you can create that value for your members, and as an organization, you're capturing that value.
And then the other thing to point out here is that because we spend so much time understanding your operational structure, we understand, your case manager interactions and where you have resources or where you potentially lack resources. We have the ability to fine tune these recommendations to plug right in with the way you're currently set up. So if you have the capability to send case managers to physical locations, we'll consider that in the recommendations. Or if you have a call center that you'd prefer to use, we also have the ability to work specifically in those modalities. So again, a very flexible system, very much focused on campaigns with KPIs that we track as the campaigns evolve, trying to move beyond just giving you a set of numbers and a set of predictions, but giving you actual recommendations to make these members, have better outcomes in the real world. And then again, just very briefly, for this particular case study, for anyone who's interested, please reach out. We have a more detailed write-up on this particular group of members that we reached out to and how we improve the outcomes for that particular group. But as I mentioned, this was a marketplace plan. So one of the big goals for them was to just retain these members, over a period of time. And for this particular group, quite a few of them were at risk of leaving the plan during the renewal cycle. But for this particular group, with the increased engagement from the case managers and the increased focus from this campaign, these members then end up increasing utilization of preventative services, and that then translated into better perceptions about how the plan was providing care to them, that then ultimately led to more engaged members that renewed their membership. So again, very happy to kind of do a deep dive on that. Feel free to reach out. But overall here, it was a wonderful study to work with, given the fact that these members had very difficult health-related social needs. We could identify how to reach them, how to engage with them, what the key obstacles were, and working with partners and community-based organizations, trying to get them to utilize the benefits that were available to them, and then being able to track, in dollar terms, the benefit that we provided to the client with this particular cohort of members.
Yeah, and then going back to Deborah's question earlier, just about, where does it go from these insights? This particular plan did launch because we found transportation was a barrier across a number of different cohorts. So they did launch a pilot with the transportation provider, and now have gone statewide. But again, they're allowing these insights, these targeted insights, to drive the allocation of those resources, and so it can be used to drive or organize an existing program, or to Kim's point, it can also be used for planning purposes as you're considering certain solutions and where you're gonna deploy those solutions. And then the last thing is, health happens at the speed of trust, as I've heard before, and that's what we're talking about here. We're talking about enabling one of your care managers to enter into a conversation with a member, knowing as much as they possibly can, so they've got a great starting point to start building that relationship and ultimately getting connected to the services and supports that they need. So, all right, looks like we got another question. All right, Kirk asked about D-SNP plans in California. We are not working with any plans in California right now, Kirk. We are working with the D-SNP plan, but would love to get into that, because I think that the question that we sometimes hear from clients early on in the process is, does this technology work for different populations in different areas? If you've got a model that's a Medicaid model in, say, New Jersey, is it going to work in Montana, for example, on a Medicare plan? And the answer is it does. And the reason it does is we train these models exclusively on your data. We'll get into some performance measures later, but no, we have not worked in California, but I'm confident that the stuff we're talking about here would apply. So, Eben, is this one back to you?
Yeah, I can very briefly mention here, obviously, the KPIs that we work with can be framed by your team, right? So a very blunt KPI would be that their costs decrease or change, or that their ED utilization change. But for this particular client and this particular campaign, they were very focused on improving utilization of services for this particular cohort of members that had this transportation barrier that they had to overcome. And then the way we measure the KPI for this particular campaign was to actually see what proportion of the members in this group utilized physical health services in the 6 months after engagement, or what proportion of them increased behavioral health services in the 6 months after that campaign. And again, with these particular metrics, we could see a very significant improvement in utilization for these members that, we hope is the first step on their journey to having better outcomes. And obviously working with our clients to provide continuous recommendations for these members to try to improve their health outcomes, despite their very challenging, SDOH challenges that they are facing at the moment. And then again, obviously, when you look at the sort of the breakdown of the kinds of services that these members utilize, you can see their trends before renewal and after renewal. And the good news here is, as I mentioned, behavioral health utilization is significantly higher. And then in terms of just HEDIS, like cancer screening, types of measures, we also saw a very significant lift in cervical cancer screening rates and colorectal cancer screening rates for this group of members, obviously with the preventative services and some good quality measure improvements for those too. And then lastly, just the other thing to call out, if you go to the previous slide, for this particular group of members, because they were in a very rural part of the country, there was an increased ED utilization for this particular group of members But that was mainly a function of the fact that they just didn't have access to nearby facilities, and that ED in general was a more appropriate point of care for them.
All right.
So again, thank you for all the questions. I see a couple of questions. Bear with me for a moment. Oh, perfect. Deborah, you just asked the question. How do you partner with the plan to integrate the data? Which is exactly the next set of slides. So hopefully the next set of slides answers that question. The first thing to say is that we have a very flexible data system. So we understand that everyone has data in unique formats, that you probably have siloed data sets. There's a random spreadsheet over here. There's a more standard database over here. We've seen everything, and we're very familiar with that process. So we really try to work with what you have, and we really try to focus on getting a quick win as quickly as possible. We have absolutely no intention of taking several months to onboard your data. We also never tell you to package the data in a certain format. So whatever format it is in right now, provide it to us, and we'll start working with it. The kinds of data we expect to see would be enrollment data, demographic data, very critically, if you have zip code or address data for those members, that's extremely helpful for us to work with. And then any kind of claims data that you can share with us, pharmaceutical claims, behavioral, physical, and so on. Anything where we can see an ICD code, a procedure code, or an NPI code for a care provider, or an NDC code for a pharmaceutical product. Any one of those variables we could then ingest into our system in order to generate predictions. And then very critically, we have a capacity to absorb your operational data. So if you have a file that tracks your case manager interactions, we can ingest that. If you have text notes of phone calls from your call center, we can ingest the text-based data as a way to augment that. So I really wanted to just emphasize that all that data kind of paints a picture, and that the focus is to get that data processed as quickly as possible in order to start generating insights and to start generating potential campaigns as quickly as possible. Because the most useful data to collect is actually the data that you're collecting in real time as these campaigns are in the field, and as you're trying to make a difference for these members, creating those data sets to feed back into the system. So hopefully that answered the first part of your question, Deborah. Feel free to ping us if you have another question along those lines.
And Evan, just to put a fine point on a few things that you mentioned, I mean, to give folks a sense of how quick we're up and running, it usually takes us about 90 days for us to get you back your first report after getting your data, full profiles with predictions by day 120, and then we're off into the campaign planning or initiative planning. The other thing I would mention is these are kind of the foundational data sets. There's often other data sets that are very use case specific. So for example, we had a client that was working on a project around deinstitutionalization and then keeping those folks in a stable setting post-transition. They had a file which basically identified how many times a peer support specialist went to their place, knocked on the door, and it went unanswered. Found a lot of signal on that. So call logs, customer satisfaction, you name it, we'll take it. And if there's signal in it for the specific use case we're working on, we'll pull that signal through and use it to refine those models.
And one other topic to mention here is just the topic of data quality. Inevitably, like there's usually some problem somewhere with the way data was collected, just data quality issues. It's inevitable in the industry that we work with. So we do spend a lot of time initially trying to evaluate the quality of the data sets and try to identify where there are data sets where we feel good about the quality of the data. And then identifying what parts of the data that you've shared with us are reliable in order to build, forward-looking campaigns with. So in that initial period, it's a very close collaboration between us and your data teams to try to understand some of the challenges that might be present in your data, and to try to focus on, how we can move forward with the data in whatever format it comes into. Because obviously we don't want to have a situation where it's garbage in and garbage out. So very much focused on working with your team to really understand the nuances of your data. And again, reiterating what we mentioned earlier, that this is not some off-the-shelf piece of software that's just plug and play. clearly there's a lot of thought that goes into understanding, the uniqueness of your data set and training our models on the areas of your data that you understand best and that you think is high quality and that we can validate as high quality. And to us, that's really where the magic happens in this data transformation process. So as I mentioned, we take your data and we have our own data sets that we then fuse with your data in order to augment everything that we're doing. So as I mentioned during the case study, if you can provide to us location data, we have tens of thousands of variables sourced from the CDC and the government and various marketing research organizations and so on, where we can build data on the physical environments that these members live in, right? So that's the first sort of big fusion data set that we provide. We also have data on housing, demographics in areas. And then, as I mentioned, we have a very deep understanding of the social network that is embedded into your claims data. So really taking the time to take the data that you've shared with us and understanding the connection between the care providers that we observe in your claims and the members in your claims data, and understanding what that connection looks like and the frequency of those engagements and which of those engagements are leading to good outcomes. We also have a wide range of data sets on pharmaceuticals usage. So understanding what is the active ingredient in a particular pharmaceutical that this member is prescribed, and then understanding what the sequence of diagnoses might look like for that member, given the fact that they're taking that type of medication. And then very critically, when we design these campaigns, we try to fuse your members to what we call digital twins. So it's this notion that if we understand what someone's history of claims look like, and we understand what their environment looks like, and we understand basics about their demographics, their age, gender, how many months of eligibility they have, and so on, we have the ability to then find identical lookalikes in historical data sets that look like the members that you currently have in your membership. And if we have interventional data on those members, we can then simulate what those campaigns might look like for your membership in order to do a proper cause and effect estimation. And again, we don't have too much time to go into the deep dive on that today, but feel free to reach out to us and we'll do a technical conversation around this idea of modeling the campaigns that we recommend along these lines of digital twins that we've collected from thousands of different data sets across time.
And Evan, this is where, as we thought about building this company, that the piece that Evan just shared was the counterpoint to the managed care experience. That's why people like Kim, people like Renee that have been nurses or have run care operations, that's why they're so critical. We're never removing the human from any of this decision making, but rather accelerating or making the context by which the human's making the decision that much more rich for them to evaluate and move more quickly, have a really good jumping off point. But at the end of the day, it's really about the individual making the decision. And Deborah, I saw your note about implementation time. It is fast, and that was a key design element as we thought about it. Having sat in a managed care kind of executive seat, these things would often take 2 years, and they often wouldn't result in the type of outputs that you wanted. And so as we thought about building this, that was another really important one, is let's get to answers quickly, let's get to initiatives quickly, and then let's continue to scale from there and find more opportunities to take on to improve member health. So.
And I want to make a comment on the implementation piece. I think us having a short implementation piece is critical to our clients, as many of our clients are looking to achieve their NCQA health equity accreditation. Time is valuable. And so we want to come in and make sure that we're partnering with you and we're getting you up very quickly. Again, we have so many data resources. We're doing this data 20. We have individuals like Evan and others on his team who are experts at working with your team to make sure we can meet that implementation timeframe. So we recognize that you have regulation and compliance standards that you have to meet, and we want to make sure that you hit those. And so that's why our implementation, we purposely make sure that that implementation meets your needs and doesn't drag on to what Trey said, 2, 3, and 4 years. We want to drive to measurable outcomes.
And then just for just like a minute, just to because I know we're talking very sort of abstract. A very obvious question might be like, so what do you get when you use Siftwell? So on the previous slide, essentially we generate PowerPoint slides that's intended for a C-level audience that you could potentially share high-level trends with your team and direct reports. We also generate Excel spreadsheets that's meant for helping you identify like the individual members in the campaign with some metadata about them. So that's one way that we actually produce the product. We also produce interactive dashboards around very specific topics. So if your team members want to have a web interface to explore your data with, we can get that set up for you quite quickly as a way to augment the PowerPoint decks and the Excel spreadsheets that we share with you. And then lastly, for organizations that have a more mature technology infrastructure, if you have the capability to ingest raw predictions, we can also send raw predictions directly to your FTP site. Or if you have capability to ingest data through API, we can also send you data through an API system. So it's been an interesting journey. We've worked with clients with very high technological sophistication, all the way down to, we can't even handle more than 1,000 rows in a spreadsheet. So again, we want to be mindful of what your operational capacity is when we generate these outputs and to make sure that we send it to you in a way that is most useful given how you're currently set up. And then,
Evan, do you want to do this one?
Yeah,
go ahead.
I'll very briefly talk about this. But again, just the main message here with this particular slide is that we are not some off-the-shelf predictive engine that is based on a deterministic set of if this, then that, add a score point to this if someone has this characteristic. What we've built is a system that leverages the latest breakthroughs in causal machine learning that we can train specifically on the unique characteristics of your data. So this particular member or this particular client, they were using a very well-known industry benchmark tool for risk stratification. And they wanted to do a side-by-side comparison of our predictive models against the industry standard model. And what they found is that our system was significantly better at identifying members that were likely to increase in cost over the next 12 months. So, for example, this particular system, if you rank their top 500 riskiest members against our top 500 riskiest members, our cohort of top 500 members had an average cost of more than $20,000 over the next 12 months compared to the $10,870 on a PMPM basis for the competitor products top 500 risk. We were very surprised by this, but the explanation is quite simple that this particular member had very unique populations. They had members with significant mental health challenges. They had members that skewed younger and skewed more rural. And in that scenario, it doesn't make sense to use some off-the-shelf piece of software that's trained on general population US demographics to make those predictions. So what we found is that the system identified younger members that tended to be more female that had higher risk than this competitor product was detecting. So again, that ability to tune the models to your unique characteristics and also to very deeply understand the connections in the communities where your members live help us build these models that are significantly better at identifying risk. And again, this is a very narrow definition of risk, which is purely cost, but we could also have extended this modeling to other areas like ED utilization, repeat inpatient visits, and then on the positive side, being able to predict things like compliance with cancer screenings and certain types of medical adherence. So again, happy to do a deep dive in a technical conversation. Feel free to reach out to us.
Hey, Evan, I got a question about inherent biases. How do you prevent societal biases leaking into the modeling decisions?
That's an excellent question. We only have 14 minutes, but that's a topic we can talk about. The key thing to observe is that traditional correlational machine learning perpetuates bias. I think most industry participants very deeply understand that. I'll try to summarize it in 20 seconds. It's this idea that if you look at claims data, certain demographic groups have higher utilization than other groups. So if you build a correlational model that predicts risk, members that have more claims will have higher risk. So white populations, they tend to visit the doctor more often. So a risk model would say white people are riskier than black people, allocate resources to white people. That then perpetuates that bias that we've observed in historical data sets. What makes Siftwell unique is exactly that digital twin approach that I've mentioned earlier. That idea that we're not using correlational machine learning, we're actually using causal machine learning, where we automatically control for things like race, gender, and regional dynamics in order to identify the true cause of someone having an adverse outcome, and making sure that we address the root cause of the problem as opposed to a correlational bias that might exist in the data. So that's definitely a huge differentiator for Siftwell. Just the kinds of models that we build directly address that bias that's inherent in the data. And we go out of our way to actually track the fairness of our models, where we make sure that the recommended campaigns, demographic distributions line up with the distributions in your membership. But then, as Kim mentioned at the very start of our conversation, health equity is a very common theme for our clients at the moment. So being able to use these models to identify who is at risk, why are they at risk, and is there a particular gap in care for members based on their demographics? And being able to identify where those areas of opportunity lie has been very informative to help address those issues. So that's an excellent question, and definitely an area that we want the industry to do better on, and we're very excited to try to be a part of that improvement and addressing the bias in data, but then also pushing ourselves to find ways to remove it out of all the recommendations that we generate.
Yeah, and the things that I would add that extend beyond the technology piece that Evan just talked through is, we're a mission-based organization or mission-focused organization. Our clients are mission-focused organizations. Many of our team members came from ACAP plans, and 75% of our clients currently are ACAP plans. And the ones that aren't are the ones that we know and trust that they'll use this technology for the right reasons. And then you always keep the human in the loop as well. So kind of non-technological guardrails as well. So
I just want to build on what Evan said about causal inferences. Claims may show higher utilization of one demographic, but what is unique about Siftwell, a few slides back, Evan talked about the different curated variables that we put into the data: environmental, behavioral, housing. And so there is a data set we have around environmental justice index, looking at those areas that have homes or zip codes by highways. We know that pollution, you may see more asthma. And so we would say there's underutilization in this community, but we know there's a higher prevalence of asthma. The question is why. So going back to the beginning when we talked about root causes and challenges of SDOH, when we talk about behavioral, their likes, their values, taking into account cultural preferences and attitudes that may drive why a certain demographic may or may not be utilizing. We have one demographic that the women, because of their religious practices, will not go to the doctor without their husbands present. Well, their husbands are working during the hours that the providers in their area are available. So now we're looking at availability. So when we talk about access, it's about the availability of those providers for those women who practice that particular religion. So we take all that into account, and that's why we emphasize we look at your root causes of over and underutilization.
all right.
That's the causal piece.
Thanks for that ad, Kim. Yeah, so I think we're probably going to wrap here unless there's other questions. But before I do, I'll ask one of our team. How would a plan know whether we could help them or not? Evan or Kim, any thoughts there?
I'll go first. I think, if you have location data for your members and you have some data of past campaigns that you've like attempted to try and improve the outcomes for your particular members, we have the ability to ingest your internal operational data with any kind of additional data that you have in order to evaluate campaigns that you've run before to see if they were actually effective or not, and to try to immediately learn from what you've tried before and try to translate that into your current membership. Again, the goal here is not to turn this into a months-long IT project. No one wants that. The goal is to try to understand really quickly what's working and what's not, give you a quick win to try to get that feedback cycle going and focusing less on pretty numbers in a dashboard or a piece of software and more on what do you need to do in the real world to make a real difference for these people. And in order to do that last piece, you don't need to work with like tech people like myself. You need to work with real operators like Trey and Kim that know what it takes to like take an insight and make it happen in the real world and understand the context of the healthcare system and managed care, like how to make a difference for these members, and being able to kind of work with those previous operators to help augment your internal way of addressing the opportunities with the data, I think is the best way to get going with Siftwell. Kim, I don't know if you want to add to any of that.
No, I mean, Evan, I think that's great. When we say campaigns, we're talking about the programs that you have in place, and maybe it's even your processes, right? So hopefully our insights um, give you that view at your macro, meso, and micro level. We just had a client that said, wow, our diabetes programs aren't working. Maybe your diabetes programs do work, but perhaps you're not targeting the correct population, the correct cohort for those programs. Perhaps there is something within your process that can be improved because it's about continuous quality improvement. So it's not throw everything out. We really come in and say, these are the insights, and how can you use those insights for improvement, maybe to design and develop a new program. When we say in campaigns, we're talking about programs. So sometimes in the NCO world, when you're doing population health clinical operations, a campaign is for a short period of time, but it could be actually your program. We'll take all data that you have, your health risk assessments, your health outcome surveys, your clinical needs assessments, whether it's your clinical team doing collecting that data or your non-clinical team, your member engagement teams, your community outreach teams. All of that information matters, and it allows us to help you look at your data differently, not look at it as you have in the past. We're trying to break the status quo. And not to sound cliche here, but we want to be disruptors with you to disrupt this cycle and really advance and address social determinants of health and health equity initiatives.
Yeah. The only thing I would add to all of what Kim and Evan said was how to know whether we can help you. Reach out. Let's have a conversation. If we can't, we'll tell you that honestly. No pressure. Would love to learn about your organizations and what your priorities are. So please reach out if this is interesting to you. And then Deborah had one last one just on pricing model. Usually it's a fixed fee and then an annual fee, or like a setup fee, Deborah, and then an annual fee. And the reason that we do that is oftentimes what we identify as folks that are going to come out of the shadows. And the reason I've got this slide back up is what you can see on the right-hand side. Folks that were labeled as moderate, their current understanding of a large swath of members, they actually had labeled as moderate when in fact they were emerging risk and kind of came out of the shadows from a PY perspective. And so we like to get your entire membership, scour your entire membership for opportunities, particularly the individuals that are in the corners, that we can improve their health and strengthen those communities. So that's why it's a fixed kind of all you can eat model there. So again, huge thank you for joining us today. Appreciate you taking the time and reach out if you got questions.
Thanks, Trey. I really want to thank the whole Siftwell team for today's session. As a reminder, today's session has been recorded and will be posted along with the slide deck on the SDOH Health Equity Showcase website. You can find that under events on ACAP's main page, which is www.communityplans.net. Thanks for joining us today.
Thanks, everybody.